Hello, this is Dr. Tobias Carling from the Carling Adrenal Center and the Hospital for Endocrine Surgery down here in Tampa, Florida. We're hosting this Carling Adrenal Center Facebook Q&A. So thank you all for being part of this. And we received a bunch of questions on Facebook and Instagram and YouTube and TikTok and so forth. So we're going to try to go through all of them. And as you are participating, definitely feel free to send in questions as well. Questions about adrenal tumors, adrenal surgery, and anything related to the adrenal glands. So we'll get right to it. This question is, I have been experiencing symptoms like fatigue, dizziness, salt cravings, and my doctors think it might be related to my adrenal glands. How do you decide whether surgery is needed or if medication and monitoring are enough to manage these symptoms? All right, that's great. So when it comes to symptoms, I want to make a couple of comments as we get going. When you see a doctor, it's very important that you're very specific with your symptoms. So for instance, a lot of adrenal tumors cause high blood pressure, some cause weight gain, some cause fatigue, and a lot of other symptoms. So when you go to the doctor, doctors try to, they see, especially primary care doctors, but even medical endocrinologists, they see all sorts of different patients, and the more specific you are about your symptoms, the better. So for instance, if you have high blood pressure, make sure you log your blood pressure at least twice a day, write it down meticulously, and bring that data to your doctor. Doctors want to see data. They want to see, you can go to the doctor and say, I feel tired and fat, okay? That's not that specific. That's not very helpful. Whereas if you say you're tired, for instance, you say, well, 3 years ago, I slept 7 hours a night, functioned fully, I never took a nap, but now you go to the doctor and say, I have to sleep 10 hours a night, and every single day or every other day, I need to take a nap. That's very specific. Same thing with the blood pressure. Same thing with weight gain. You want to know, or you want to tell the doctor, I have gained, say, 20 pounds over a 6-month period of time, and show data when it comes to that. So try to be as specific when you describe the symptoms to your doctors. It makes us as doctors, it makes it easier to decipher whether you have an adrenal tumor or not. But when it comes back to this patient who has fatigue, dizziness, and salt cravings, well, that can be related to a lot of things, but certainly can be related to the adrenal glands. And when you want to work up a patient for adrenal tumors, you basically want to rule out 3 types of tumors: those that are overproducing aldosterone, cortisol, and catecholamine or adrenaline type hormones. To measure the aldosterone levels, you need to measure both the aldosterone level and the renin and the potassium. For cortisol producing tumors, you want to measure the cortisol. The best tests are the ACTH, which is the pituitary hormone. That's typically low when you have an adrenal tumor. A low dose dexamethasone suppression test, that's when you take a pill at 11 p.m. in the evening and then measure the cortisol the next day. If that's 1.8 or above, that's too high cortisol. That's the low dose dexamethasone suppression test. And thirdly, the DHEAS. And then you have the adrenaline type hormones or tumors, meaning pheochromocytomas, and testing for metanephrines or catecholamines, either in the urine or in the plasma. That's the first way to start. And if you have any positive testing of that, then the next step would be to do an adrenal protocol CT scan. But again, just to get back to that first point, try to be as specific with your symptoms as possible. If you have headaches, write down how often you have headaches. How long do they last? Do they last for 5 minutes? Do they last for 3 hours? Try to be as specific as you can when it comes to your symptoms. All right, next question. I had my left adrenal gland partially removed in June due to a tumor. Now I need to have my right, I think this end, there's something going on here, Julie. So we'll just click that away. Okay, we're back. Just apologize for that, just some technical issues. So the question is, I had my left adrenal gland partially removed in June due to a tumor. Now I need to have my right adrenal gland done. The tumor on the right is smaller, 11 millimeters or 1.1 centimeters. How much of the gland would you leave behind if only part of it needs removal? Is it better to remove the smaller tumor now, or should I wait for it to grow larger before surgery? All right, there's a few questions in one, but it basically deals with two topics. Topic number one, which a lot of patients have questions about, and it's a very important thing, has to do with partial adrenal surgery. We have two adrenal glands, the right side and the left side. To have normal adrenal function, it's enough to have a third to a half of one gland. So a third to a half of one gland. So that means you can remove one and a half or 1 2/3 of all adrenal tissue, all adrenal cells. As long as you preserve a third or a half of an adrenal gland, you don't end up being adrenally insufficient, or another name for that is Addison's disease, meaning you have to take supplemental hydrocortisone. Okay, so when you have tumors on both sides, there's two goals with operation. Goal number one, get rid of the tumors. Goal number two, preserve enough adrenal tissue that you don't need to take long-term steroids. So if you had surgery on one side already and now you have a tumor on the other side, the goal would be to remove that tumor and preserve adrenal tissue. And the other factor which this patient alludes to has to do with the size of the tumor. So in general, the bigger the tumor, the less normal adrenal tissue there is to preserve. So for instance, a 1.1 centimeter tumor is pretty small, so it's pretty straightforward to do a partial adrenalectomy in that patient. Whereas if the tumor is 5 or 6 centimeters, there's not that much remnant left behind that you can actually preserve, because most of the normal adrenal tissue is taken up by that big tumor. So it not only depends on the size of the tumor, but also what the hormone testing shows and so forth. But certainly a smaller tumor in general is more straightforward to preserve adrenal tissue than a larger one. But deciding exactly the timing of the surgery depends a little bit on what the hormone levels are and so forth. But in general, partial adrenal, so we do more partial adrenal surgery than anybody else in the world. So we do a lot of these operations. And what we do, number one reason for that is that we operate on a lot of patients that have surgery both on the left side and the right side, because they have bilateral tumors, meaning they have tumors on both sides. The other reason is that we do know, especially for patients that have cortisol producing tumors, Cushing syndrome, even if they only need unilateral surgery, meaning only surgery on one side, preserving some normal remnant on that side reduces the number of days as well as the dose of hydrocortisone they need to take. So whenever it's the right thing and whenever it's physically possible based on the tumor size and the risk of cancer and a number of other factors, we preserve adrenal tissue. I was diagnosed with Cushing's syndrome and had surgery in October 2023. I am no longer taking hydrocortisone, but I still take 0.5 milligrams of fludrocortisone. Will I need to take this medication for the rest of my life? Also, if I get sick, should I take a stress dose hydrocortisone given that I have only 30% of one adrenal gland left? Okay, so there's a couple of questions. So after when we replace, so a small proportion of patients with Cushing syndrome, as I mentioned, need some supplemental steroids temporarily after surgery. So we typically replace cortisol, which is hydrocortisone, and we replace aldosterone, or the mineral corticoid effect similar to aldosterone, and that's the medication fluorocortisone, or the brand name for that is Florinef. Okay, so that's the question the patient has, should she take or he take Florinef the rest of their life? No, it's not necessary to take Florinef the rest of your life, especially if you're off hydrocortisone. However, you should discuss that with a doctor, because there's some instances where you use that medication to treat other things. For instance, if you have an imbalance in your potassium and your sodium, you may need to be on that medication. So talk to your medical endocrinologist about that. Also, if I get sick, should I take a stress dose of hydrocortisone? Well, if you already weaned off hydrocortisone, that means that the adrenal cells you have are functioning normally, and that's what we check in the hospital the day after the surgery. If anybody of you have had surgery, remember at 4 a.m. you get woken up and they come and do lab tests, something called a cosentropin stimulation test. So if that's completely normal, or it was abnormal but now you weaned off the hydrocortisone, that means your adrenal glands are functioning normally, so that there's no need to take any stress dose of hydrocortisone. After having the mini-back scope adrenalectomy surgery for an adrenal mass, how likely is it that my adrenal glands will resume normal hormone production? Is there a percentage of people who end up needing lifelong hormone replacement after surgery? Yeah, so we talked about this a little bit, but assuming that you have at least a third to a half of one adrenal gland, so 0.3 to 0.5 of one adrenal gland, or 30%, 50% of one adrenal gland, you have enough adrenal hormone production that you don't need to take steroids long term. In cortisol producing tumors, the tumor has suppressed the normal gland. So once you remove the tumor, the normal cells of the adrenal gland are a little bit sleepy, so it can take a few weeks to months for them to wake up. And the more severe Cushing syndrome you have going in for surgery, the longer it takes for those adrenal cells to kick in and start working. But long term, they're going to start working. It just can take some time. So assuming that you have that much adrenal tissue, there's not any patients that going to need lifelong hormone replacement after surgery. Having said that, though, if the surgeon is not very careful in preserving the blood vessels to the adrenal gland during surgery, a surgeon could technically preserve adrenal tissue but damage the small blood vessels to the adrenal gland, and that leads to the same effect, meaning you don't have any cortisol production. But as long as you have a partial surgery at the Carling Adrenal Center, where we do this day in and day out, we preserve those vessels and you're going to have normal function afterwards. Do you offer or participate in clinical trials related to adrenal diseases or tumors? I would be interested in learning more if so. Well, this gives me a great opportunity to talk a little bit about the Hospital for Endocrine Surgery Research Institute, which we're launching, or we launched last year. And this is a whole research program focused on adrenal, parathyroid, and thyroid tumor disease. And we already have published a number of papers, submitting abstracts. We're looking at really telling the world about what we do and our patient outcomes and so forth. So there are some clinical trials that we're doing. At this point, we're not putting patients on medications or chemotherapy or stuff like that, but we're doing clinical trials in the sense that we're evaluating patients. And as we are rolling this out and building this infrastructure, we are over time going to increase the things that our research institute offers. In 2018, I was diagnosed with unilateral adrenal medullary hyperplasia. My adrenal glands appeared normal on CT and MRI, but my left adrenal showed abnormal focal uptake on a MIBG scan. Should I get updated scans before deciding if surgery is needed, considering I haven't had any follow-up since 2018? Okay, so this is a very important question about adrenal medullary hyperplasia, which you can think of as a pre-form to pheochromocytomas, meaning to adrenaline type tumors. So an adrenaline type tumors, pheochromocytomas, can show up on a MIBG, and we do see patients that have positive MIBGs but negative CT scan, meaning you have uptake in the adrenal glands, but there's yet to be a distinct tumor there. So what I would recommend for this patient is to continue to follow the catecholamines or the medanephrines. If you haven't had a scan as far back as 2018, I do think it's probably going to be time to repeat that scan. Having said that, though, MIBG scans can be false positive as well, meaning that they show uptake, but there's really nothing there. So just be a little careful with those scans. They're not 100%, they're not perfect scans. So talk to your endocrinologist, see what your labs are, but it might be worthwhile to get another scan to see where you're standing at this point. Okay, this is a question from Instagram about myolipoma, adrenal myolipoma. So I have an adrenal myolipoma that my doctors say isn't causing my symptoms like weight gain, flushing, and high blood pressure, but I'm still suspicious. Could my myolipoma be the source of these problems? Okay, this is a great question. So adrenal myolipomas are tumors arising in the adrenal gland, but they don't arise from adrenal cells. They arise from adrenal fat cells. So if it is a true adrenal myolipoma, they shouldn't overproduce cortisol, aldosterone, or catecholamines, meaning these are non-functional tumors. However, there's a couple of things that are important to know, that occasionally we see a bigger adrenal myolipoma on a scan, but it can mask a smaller functional tumor. So it's important to check all those labs that we talked about, aldosterone, cortisol, and adrenaline hormones, number one. Number two, sometimes adrenal myololipomas, even though they're benign and they're non-functional, needs to be removed, because sometimes they cause compression of surrounding structures, pushing on the kidney, pushing on the liver, pushing on the kidney. Rarely, but occasionally, if they grow, they can rupture, and some other issues. So the vast majority of adrenal myololipomas, if they truly are myololipomas, should be non-functional. They should be stable over time, and not all of them needs to be removed by surgery. But certainly, if you have lab tests that are concerning, or there's something else going on, it's important to have that investigated. My son had a pheochromocytoma removed, and now I'm wondering if the rest of the family should be checked. Is this hereditary? Yes, this is an important question. So 20% of patients with pheochromocytomas have an underlying mutation in a gene that makes them susceptible to pheochromocytomas. There's about 13 different genes that's been identified. So it depends a little bit on the age, but we do recommend, so the younger the patient is, so in this case the son, the higher the risk of it being a genetic type of pheochromocytoma. But bottom line is, we recommend that all patients with pheochromocytoma should have genetic testing done, because if it's positive, that's very helpful to know, because then the first degree relatives should be checked, and you can remove those pheochromocytomas before they cause any problem. And B, if the genetic testing is negative, that's helpful information too, because then you don't need to worry about the genetic type of pheochromocytoma. So absolutely, that would be my recommendation. All patients with pheochromocytoma, or paragangliomas for that matter, should have genetic testing. That's my recommendation. Can you help with adrenal tumors that are causing fluctuating blood pressure and other symptoms, even though they aren't showing up as clearly dangerous on imaging tests? My doctor says everything looks normal, but I still have symptoms. Yeah, this comes back to that first question. Try to be as specific with your symptoms, write it down, keep a very close track on your blood pressure and the other symptoms. Show that data to your doctor. Again, most adrenal tumors, if they're functioning, cause high blood pressure, so that should be ruled out. Again, you should be checked for aldosterone-producing tumor, cortisol-producing pheochromocytomas. I should say, which is an important point, every single week I talk to patients that are convinced, they and their doctors, that they're convinced that the patient has a pheochromocytoma because the blood pressure is fluctuating. A lot of those patients actually have primary hyperaldosteronism, meaning a aldosterone-producing tumor. So the symptoms can overlap between the type of adrenal tumors. But check those hormones, number one, and then if any of the hormone testing is suspicious, then the next step would be to get a CT scan. And this is a question from YouTube. I had some slightly elevated DHEAS and cortisol levels in my morning lab work. I also have a 2 centimeter adrenal nodule. Should I be concerned about this? Should I get further testing, especially given that other tests like the aldosterone catecholamines and 24-hour urine came back normal? Yeah, so this is a patient with a 2 centimeter adrenal nodule, and she's asking about DHEAS levels. And DHEAS levels is a type of steroid hormone that's produced by the adrenal gland, but it's very important because it can be a concern both if it's high, but also if it's low. So we actually wrote a blog that I recommend you read about DHEAS levels specifically. But if the DHEAS levels are very high, that can indicate the androgen producing tumor, meaning it's overproducing precursors of, for instance, testosterone. And that can be a concern for adrenal cancer. But then also low DHEAS levels is concerning because that often signify cortisol overproduction. But if the DHEAS levels are only slightly elevated, but in this case the cortisol levels are elevated too, so I'm a little bit suspicious that this is a cortisol producing tumor, subclinical Cushing syndrome or mild autonomous cortisol secretion. So I would have to review all the labs. Again, of course, not every single adrenal tumor needs to be removed, but with a 2 centimeter tumor and cortisol levels that are borderline, I would have to review the whole panel. Again, the 24-hour urine-free cortisol is only abnormal in 5% of all patients with subclinical Cushing. So you have to look at the whole picture. You have to look at the ACTH level, the low-dose dexamethasone suppression test, the 24-hour urine-free cortisol, and saliva cortisol if that's been done. So I would have to look at the whole picture. But I encourage all of you to read that blog about DHEAS levels, very important hormone to know about. I suspect I have a pheochromocytoma, but my doctors haven't confirmed it yet. What tests do you recommend I request from my current doctors to get a clear diagnosis? How accurate are these tests in detecting pheochromocytomas? Yeah, so pheochromocytomas are almost always diagnosed by the lab testing, meaning either the plasma or the 24-hour urine-free metanephrines or the plasma catecholamines, plasma metanephrines. And that's pretty accurate in diagnosing pheochromocytomas. And if those are elevated, the next step would be to do a scan, and the first line of scanning is a CT scan. But pheochromocytomas can be a little bit tricky sometimes in the sense that they can be located not in the adrenal gland, they can be extra-adrenal. you can rarely have, and we published about this, what we call silent pheochromocytomas, that the hormone levels are normal, but you still have a pheochromocytoma. And then you have some additional imaging as well. But start with the lab test and get a CT scan. Then there's some functional imaging studies, as we talked about, both PET scanning and MIBG scanning. But I would only pursue those type of scans if the catecholamines are suspicious or elevated. But that's where I would start. And again, for a lot of patients that suspect that they do have a pheochromocytoma, they actually turn out to have primary hyperaldosteronism and aldosterone-producing tumors, so that's important to know. If I have an adrenal tumor, is it always necessary to remove the entire adrenal gland, or can the tumor be removed alone? How do you determine the best course of action when deciding how much of the adrenal gland to remove? Yeah, so again, this is a question about partial adrenalectomy, and we do get a lot of questions about partial adrenalectomy, and that's a very important topic. And we published on the website widely about it, but bottom line, it's always a good idea to preserve adrenal tissue whenever it's the right thing and whenever it's feasible. So again, the important factors whether you can perform partial adrenalectomy is what type of tumor it is, the risk of cancer, the size of the tumor, and its interaction with the major vessels in the area. But since most adrenal tumors are benign, and as I mentioned, if you have a cortisol producing tumor, it's actually been shown that the extent, so the more adrenal tissue you can preserve, the less time you need to be on steroids and a lower dosage. So bottom line, whenever it's the right thing to do, we can and we do preserve adrenal tissue. So when is it not the right thing to do? Well, for instance, if there's a very high suspicion of adrenal cancer, it's not a good idea to try to preserve adrenal tissue, because it's so critical that you remove the entire cancer together with a capsule and don't have any disruption of the cells. So that's not a good idea. The other has to do with the size of the tumor. So again, the bigger the tumor, the less remnant of adrenal tissue you have to preserve. So you can think of it as a hard-boiled egg. So you have the hard-boiled egg and then the shell of the egg around it. So if the egg is pretty big and it's hard-boiled, you're going to have the normal adrenal tissue as plastered onto the hard-boiled egg as a shell, and it's not possible to preserve a lot of tissue. But the tumor has to get pretty big for that to be the case, meaning often 7-8 centimeters. So almost all cases you have enough adrenal tissue that you can preserve. So how do we know? Well, the way we know is that the morning of the operation is that I do a very specific adrenal protocol CT scan that shows me exactly where the tumor is, where the normal remnant is that I want to preserve, as well as its relationship to all those important vessels, including the vena cava and the adrenal veins. So that's how I know exactly which cells I do want to preserve. And again, as long as we preserve at least a third to half of one adrenal gland, you're going to have normal function. But I do that scan the morning of the operation, and that helps with the preoperative planning. Is it safe to remove both adrenal glands if they are overproducing hormones? I've been diagnosed with hormonal imbalance caused by both of my adrenal glands, and I'm worried about the risk of having both removed. What would my life look like after such surgery? Yeah, so again, it's very extremely rare that we remove all of both adrenal glands. So almost all patients can have partial adrenalectomies. There's some rare exceptions to that. So for instance, if you have a pituitary tumor in the brain that's overproducing ACTH, and you have had failed neurosurgery, failed pituitary surgery, and the ACTH producing tumor of the pituitary have grown back, and it's no longer possible to operate on the tumor in the pituitary, then sometimes we're forced to remove the adrenal glands, both of them, to lower the cortisol level. But that's an exception. Almost all patients can have what we call partial or function preserving adrenalectomy, even if they have tumors on both adrenal glands. And that's true for patients with primary hyperaldosteronism. So these are aldosterone producing tumors. So classically, you can think of aldosterone producing diseases as either you have a tumor on one side and the rest of the adrenal is normal, or you have involvement of both adrenal glands. And emerging data suggests that even in those that were thought to be not surgical candidates in the past, meaning you have aldosterone production from both adrenal glands, actually removing one or 1.5 adrenal gland is better than just treating with one blood pressure medication after another. If a cortisol-producing tumor is removed, does that mean my Cushing syndrome will be fully cured, or could the symptoms return? Can a tumor grow back after removal? Yes. So after removing a cortisol-producing tumor, you're cured of your Cushing syndrome. And that's the vast majority of patients. So you're fully cured after surgery. The rare exceptions when the disease can come back. So cortisol, when you have Cushing syndrome due to adrenal tumors, so about 2/3 of patients have tumors on just one gland. You have one tumor on one side, the other adrenal gland is completely normal. But 1/3 of patients have tumors on both sides. Okay, that's what we call bilateral disease. So to address when you have bilateral disease, you have to operate on both sides. And when you do that, you want to preserve some normal adrenal tissue. So the rare instances when you have disease coming back is because you've removed the big tumor, but over years and decades later, you develop a second tumor on the other side. Or you have tumors on both sides, you address those, but in the little remnant you have recurrence coming back. That's exceedingly rare, but that would be one of the reasons the disease could come back. The other is when you have adrenal cancer. Adrenal cancer is exceedingly aggressive type of cancer, and even though you remove the entire cancer, in a small percentage of patients, this cancer has escaped and then comes back as metastasis, often to the lungs or to the liver, and the Cushing syndrome can come back. But again, that's exceedingly rare. So for the vast majority of patients, meaning greater than 99% of the cases, once you remove the tumor, it's cured, and the risk that it will come back is exceedingly low, especially if it's benign. What medications would I need to take after having an adrenal gland removed? Would I be on these medications for life, or is there a chance that I can eventually stop taking them? Yeah, again, almost nobody, very few patients need to take steroids afterwards. So if you have a pheochromocytoma, you have aldosterone producing tumor, there's literally 0% risk that you need to take steroids afterwards. The exception is the cortisol producing tumor, where about 1/3 to half of patients need to take temporary steroids while the cells come back. As long as I preserve 1/3 to half of one adrenal gland, those cells are gonna kick in eventually. Again, the more severe the Cushing going in, the longer it takes for the cells to kick in. But long term, we do not render patients adrenally insufficient. You're not going to need to take medications. In fact, when it comes to medications, the goal of adrenal surgery in almost all cases is to get you off medications, not put you on more medications. We want to get you off all these blood pressure medications and other medications that are just treating your symptoms. So the goal of adrenal surgery is to get you off medications, not to put you on medications. How long does it take for the adrenal glands to recover after surgery, and will I be able to resume normal activity? What kind of lifestyle changes or monitoring would I need post-surgery? Yeah, so the recovery from the mini back scoparolectomy operation, which is the best operation, 3 small incisions in the small of your back, takes about 15-20 minutes, is the recovery is pretty quick, meaning already that same day you'll be up, walking around, take a shower the next day. You can go out for walks, that sort of thing. But we don't want you to do any heavy lifting or gym exercises or playing golf or tennis, that sort of thing, pickleball, for 2 weeks, because too much twisting and turning and engaging your core muscles put you at risk of developing a hernia. That's the main reason we want you to take it a little bit easy for a couple of weeks after surgery. There's really no other lifestyle changes afterwards. Monitoring after surgery, we recommend that you follow up with your doctor about 4 to 6 weeks after surgery, and then dependent on which type of adrenal tumor you have, you want to have hormone testing once a year after surgery. After having surgery for an adrenal tumor, how do you monitor for recurrence? Are there any signs or tests I should be watching for in the future to make sure the tumor doesn't come back? Yeah, I think we mentioned that. So the way you monitor for it is based on the biochemical testing. So for instance, if you have a cortisol producing tumor, you want to have your ACTH level and a low dose dexamethasone suppression test done once a year after surgery together with the DHEAS. If you have an aldosterone producing tumor, you want to follow up on your aldosterone and renin ratio, as well as to see what your blood pressure does after surgery. And if you have a pheochromocytoma, annually you should have your catecholamine or metanephrine measured, meaning the adrenaline type hormones that should be measured once a year. You can have that done either through a blood test or a 24-hour urine test. What's the best way to manage the emotional and physical changes after an adrenal surgery? I'm worried about adjusting to the changes in my hormone levels and the side effects of the medications. How can I best prepare myself? Well, I think the best way to prepare yourself is you're going to feel better. You're not going to feel worse after surgery. You're going to feel better. And the degree of feeling better is dependent on the type of hormone produced by the adrenal gland. But for instance, when it comes to symptoms of pheochromocytoma, so they often have high blood pressure, heart palpitation, they might develop diabetes, they have tremors, all sorts of bad symptoms, and those symptoms go away pretty much like that in the operating room. As soon as I ligate that vein, the blood pressure drops, normalizes, and they come off a lot of those medications. That's some of the most rewarding surgery you can perform in all of surgery, because patients are literally cured and fixed just like that. And so those patients feel better quite rapidly and immediately. So sure, they'll feel a little bit sore after surgery and all of that recovery after surgery, but we're often able to stop all blood pressure medication, take them off a bunch of medications. Their blood sugars often get better, their diabetes might be cured, and so forth. When it comes to aldosterone producing tumors, it's a little bit more gradual. So it usually takes a few weeks to months for the blood pressure to get better, for the potassium to get better, but we slowly work with you to peel off some of those blood pressure medications and get rid of medications after surgery. Cortisol, so I would say pheochromocytomas happen like that, aldosterone a little bit more gradual, and cortisol producing tumor is probably the thing that takes longer to get back to normal. And maybe that's what you alluded to, you're worried about side effects of the medications. So again, the vast majority of patients don't need to be on any medications afterwards, but those that do are only on a slight dose of hydrocortisone. So a lot of people are afraid of hydrocortisone because they've been used, so doctors use hydrocortisone in two different ways. One is in super physiological doses, super high doses, right? And the other one is as a supplement, okay? That's very important, because if you treat the patient with very, very high doses due to an inflammation or some other reason that you put the patient on very, very high doses of prednisone, of course that's going to have side effects. And sometimes that's needed in some certain type of rheumatology type diseases with arthritis and Sjogren's and lupus and so forth. You need to treat patients with high doses of steroids. But that's not the type of steroids you need as supplementation. That's what you would need for a short period of time. So those are physiological doses. We're just replacing what that tumor was producing. So it's completely different levels and a completely different side effect profile. So most patients do just fine on that. And then, but cortisol producing, patients with cortisol producing tumors, it usually takes a few weeks to months to feel better. And again, the more severe the Cushing's is going in for surgery, the longer it takes for the balance to come back. But for instance, which I often tell patients, is that if we look, so high cortisol causes osteoporosis, causes weak bones. And you can study weak bones very well. And we do know that in patients that have adrenal surgery due to cortisol producing tumors, if we look at the bone mass, the bone continued to heal for a full 5 years after surgery. So that tells you that the damage of cortisol that's been going on for years and decades sometimes takes a while to get better. That doesn't mean it's going to take you 5 years to feel better. Of course, you're going to feel better within days or weeks or months. But if we look at things like bone mass, for instance, you see improvements that last for 5 years after surgery. I've been diagnosed with an adrenal tumor. What is the likelihood of it being malignant? How can I determine whether the tumor is causing my symptoms before committing to surgery? Yeah, so the risk of malignancy is an important question, and that's something we evaluate and I discuss with every single patient. But big picture, it comes down to two things: the size of the tumor and what we call the imaging phenotype. So the imaging phenotype is, what does the tumor look like on a scan? We don't poke needles into adrenal tumors, as many of you know, because a biopsy can never tell the difference between a cancer and a non-cancer. And if it is cancerous, the recurrence rate is higher if you poke needles through that capsule. So if the tumor is greater than 4 centimeters, or it shows what we call interval growth, it's been growing over time, or it has an atypical imaging phenotype. So the atypical imaging phenotype factors in about 10 different criteria we look at on a scan, typically a CT scan, but it has to do with how fat containing the tumor is, how it interacts with the surrounding tissue, what the borders look like, if it's homogeneous or not, meaning it's uniform, and so forth. So all those things factor into determining the individual risk of it being cancerous. So here we got some, thank you for sending questions in. My flight home after surgery would be 20 hours. How many days would you suggest I wait until flying home? Yeah, great question. So if it's 20 hours, I presume you live somewhere either in Australia or in Asia or Africa or so. But so for people that fly in, let's say you have the operation on Tuesday, the latest you come in Monday, have the operation Tuesday, leave the hospital on Wednesday, and then you can travel on Thursday. So travel the day after surgery. For a 20-hour flight, I would probably want to wait another 1 or 2 days. So for you, I would probably plan to book off at least the whole week. And certainly we have a lot of patients that decide to enjoy everything that Florida has to offer for a few days before they travel back home. And when you fly, it's important to follow all the usual recommendation, meaning be up and around, walk, stretch your legs, make sure you don't develop a blood clot, and so forth. I have a left adrenal tumor, which I was told is a functioning tumor. It is small, under 4 centimeters, and I was told they don't remove them until they are over 4 centimeters. What do you suggest? Yeah, so that's incorrect. So if it's non-functional, then that size criteria factors in. If it's functional, meaning it's overproducing hormones, it doesn't matter if it's 3 millimeters or 5 millimeters or 1 centimeter, 2 centimeters, 3 centimeters. If it's overproducing hormones, it needs to come out. Meaning, if the lab testing shows that it's overproducing either aldosterone, cortisol, or catecholamine, the size doesn't matter, it needs to come out. So so the size criteria and the atypical imaging phenotype only factors in if it's a non-functional tumor, meaning all the hormone testing is completely normal. That's when we go by the size criteria. If the tumor is overproducing hormones, all bets are off. That tumor needs to come out unless there's some really specific reasons why you can't have surgery, like your life expectancy is very limited, or for some reason you can't tolerate surgery for some reason. All right, so in the interest of time, this is our last question again. Thank you all for having logged in and viewed this session, but this is the last question. Is there a form of hyperplasia that doesn't show on imaging? I have low and normal ACTH with mild to high cortisol. Doctors think I have an adrenal issue, but are stumped by the clear imaging. Yeah, this is a great question. So there are some forms of hyperplasia that doesn't show up on imaging. That's very rare, and it's typically related to some genetic diseases that typically occur in young patients. Typically, if you have high cortisol levels and a low ACTH, you would expect to see at least some concerning features. But this is important, and this is where experience factors in. Every single week we see reports of scans, both MRIs and CT scans, that's been completely read as normal. And lo and behold, when we review the images ourselves, there's either an obvious tumor or there's hyperplasia present. So I would have to look at those images completely. It certainly is suspicious with low ACTH levels and high cortisol, so I would have to look at those images myself. All right, well, thank you again so much, everybody who logged in, sent questions, continue to keep them coming. Follow us on Facebook and Instagram, TikTok, YouTube, all the usual social media. As you know, we have numerous interesting cases. We have feedback from patients and articles and blogs about all sorts of things that you can continue to read up. And we really appreciate this adrenal community, and I know a lot of you guys are supporting each other on this journey, so we do appreciate that. So thank you very much and have a good night.